have Vinita Acharya tonight from Penn State Hershey Medical Center. Thank you so much in order for taking time out of your busy schedule. We always enjoy having you. And I am going to turn it over to her to talk about this great presentation tonight. Obviously very relatable to the time that we're experiencing right now. I'm sure you'll have a lot of questions. So in saying that, the virtual experience is yours, Vinita.
Great. Okay, thank you, Laura, for that wonderful introduction. At the outset, I'd like to say that really none of us are experts in COVID, but I think COVID is making everybody think about it in their own fields. So I'm trying to do what I can in the field of epilepsy and how it has affected our patients. And we are all in this together. So if anybody has any additions to what I'm saying from your experiences, please feel to add. So the purpose is to discuss how this outbreak has affected the world of epilepsy. So COVID-19 is actually name of the novel coronavirus, and SARS-CoV-2 is the name of the virus that causes COVID-19. So coronavirus itself, there is not one coronavirus. Basically, it can cause mild respiratory illness, such as common cold. It can cause severe acute respiratory syndrome. That's what the COVID-19 does. It's called SARS, or Middle East respiratory syndrome. So COVID-19 is a new coronavirus disease. So when we talk about COVID-19 pandemic that's going on currently, it is mainly the SARS. And the onset of this, as far as we know, was in December 2019 in China. And this was kind of in March 2020. It spread all over. And I actually, in the end, if time permits, I may share how in the past 6 months things have evolved. Not on the medical front, but otherwise what happens. Most of us have been watching the news. I kind of compiled day-to-day events, and that will be, more for fun. But it was March 2020 that World Health Organization declared this as a pandemic, and public health groups, including US Centers for Disease Control and WHO, they all started posting updates. I used to watch the Pennsylvania update quite regularly. And in fact, we all, whether it was out of fear or whether it was out of concern, I think we got involved into it so much that typically I feel bad if I miss a show like This Is Us or something, but I used to really feel bad. I would watch that Governor Wolf and Dr. Rachel Levin. And as a matter of fact, Dr. Levin is from Penn State. I'm not sure I have listened to their presentation at Penn State so much, but we were all curious how things are going. So before we get into the neurological complications and what it does neurologically, I would just like to say all the basics, which all of us are aware, and but it would be nice to just to revise. So the transmission of COVID-19, it's spread from person to person, mainly through coughing, sneezing, and possibly talking and breathing. So there are certain terminologies used in this COVID world. Droplet is a respiratory secretion from coughing or sneezing that lands on the mucosal surface. Aerosol is a solid particle or liquid droplet suspended in air. By contact, we've been touching something with SARS-2 virus on it, or then touching mouth, nose, or eyes. And actually, there has been other possible route discussed, which is fecal matter. There is an incubation period, which is the time between exposure to virus and the onset of symptoms. With COVID-19, the symptoms actually, you may be exposed and the symptoms may show 2 to 14 days after exposure. CDC indicates that people are most contagious when they are most symptomatic. Several studies also show that people may be most contagious even before developing symptoms. So just because somebody is asymptomatic does not mean that they are not contagious. The common symptoms, as we know, are fever, cough, and shortness of breath. I'm sure most of you have gone to the hospital and filled the questionnaire. Do you have these? Sore throat, runny nose, body aches, headache, chills and fatigue, diarrhea, nausea. And this one came out the last, loss of smell and taste. And that is something mentioned in the neurological world of COVID, which I will be touching on later. So just because somebody has symptoms of COVID does not mean they have to go to the emergency room. Urgent medical attention is required when you have difficulty breathing or shortness of breath, persistent pain or pressure in chest. And this is something we see in the world of neurology, is new confusion or inability to arouse. And typically when patients come with this, we do get called as epileptologists because, as you know, often the seizures can do that. And we have one new symptom that is mentioned is bluish lips or face. So if any of these are seen, then a person should go to the emergency room. And the risk factors, as we know, people with COVID can have no symptoms. Kids typically have less severe disease, but the fatality rates are very high. And this is the CDC data, older age and underlying chronic medical conditions. So actually, as you know, that now the colleges have opened up for the fall semester. And at Penn State, what we have done is we did ask the students, because now it's a time the semester is going to end. We're going to end on November 20th, and students will be going home. So we are making sure that when the students go home, there are no people with who are immunocompromised at home. And what we had done during the semester was we kept some place where they could isolate. If students are symptomatic, we are not sending them home. It's the same thing in hospital. When people are taken care of, when we care for patients with COVID and they're ready for discharge, when they are discharged, we also need to make sure that there are no patients or their family members with any chronic medical conditions. So again, increased risk is also seen in people with heart disease, lung disease such as asthma, diabetes, and suppressed immune system. And so in our world, in the world of epilepsy per se does not pose any increased risk. And we don't have impact on pregnancy and pregnancy data. As a matter of fact, right now, we have a patient who has delivered a baby, and I was taking care of her throughout the pregnancy. And that patient herself, the ladies, they form a group of people who underwent pregnancy during COVID. And each time she came, as you know, when people are pregnant, we check their levels monthly, and I see my patients more often when they're pregnant. And it was interesting to learn the new COVID data that she was learning from other mothers. Although we were not sure that it would impact her pregnancy or the baby in any way, I'm pleased to know that they just had a baby a couple of days ago and COVID really did not impact. So, but this is something we do not know what it does in the situation of pregnancy. So there are certain terminologies used: a person under investigation for COVID. So the person who has consistent signs and symptoms and risk factors. So if somebody who has potential exposure to COVID and they are within 14 days before the onset of symptom. So at our workplace, what we do is if somebody is exposed to COVID, we ask them to quarantine. And then someone who has symptoms of cough, fever, and shortness of breath, but they are not COVID positive yet, they are we call these people persons under investigation. And a confirmed case is the same category above in the previous slide that I mentioned, with laboratory confirmed diagnostic evidence of SARS-CoV-2 virus infection. So how is it different from seasonal flu? Now that we are all going and getting, at least for us here at work, flu vaccine is mandatory. It is different from COVID SARS because it's much more severe and the fatality rate is much higher. Uh, the death rate of or for seasonal flu is only 0.1%, and that of COVID-19 is almost 20% that of the regular flu. Although I would like to mention that at Penn State, what they do is when you get these symptoms and you haven't been in contact with COVID, but you are a healthcare professional or working in a field that is at high risk, along with the COVID, we test 25 other viruses. And sometimes what happens is when this viral panel is sent, something or the other comes positive. So, for instance, if you have symptoms of COVID, but you're COVID negative, it still makes you wonder, why do I have the symptoms then? And in that case, that respiratory panel is very helpful because then you know that the fear should not be the same, because in this, the pneumonia that causes comes with also lowered blood oxygen saturation. Whereas when we get flu-like symptoms, we don't necessarily go on monitoring our oxygen saturation. And again, the main difference, of course, is there is no treatment, there is no vaccine, there is no immunity, at least as of today. Things may change in the next few days. So let's move on to neurological findings in COVID. There are comprehensive reviews of neurological involvement. The findings include headaches, anosmia, ageusia, that means loss of taste, and impaired consciousness, seizures, stroke, and vascular event, peripheral nerve disorders, including Guillain-Barré syndrome. If you recall, there was this H1N1 vaccine when people received. I've actually personally seen cases of Guillain-Barré syndrome due to that. So that's like, so similar things in the field of neurology, there is a lot of literature on it. Most of the literature actually came from China, and because they were kind of, the symptoms started there, they had probably more patients. The expert consensus of neurologists from China and COVID-19 related neurological signs and symptoms include stroke, headaches, seizures, impaired consciousness, and myalgias. So the reports from China stresses that patients present without fever. This was something I learned while searching this literature. And also when patients had neurological symptoms, they often had leukopenia, that means a less decrease in white blood cell count before the onset of neurological symptoms. I tried to look for the cause, why this happened, why they did not have fever and why they had but maybe when people do come to the clinic and have symptoms like vague headaches or myalgias, and we see that quite often, and probably we should think of at least doing their CBCs to see if there is decreased blood count. And just because the point to take from this is just because somebody does not have fever, I don't know for sure that we can rule out COVID. And so John Hopkins University and others have done a lot of research in the field of neurology, but they are the main on the forefront, and most of the data is from the Hopkins registry. What do researchers think how COVID impacts brain? So first of all, severe infection. The first possible way that the virus may have capacity to enter the brain and cause severe and sudden infection. Cases reported in China and Japan found, how can we prove that this is the virus going into the brain? And I think we have one case reported from the US or from Florida, but mainly the cases from China and Japan. They found that virus is genetic matter in spinal fluid, and so it's kind of trying to establish a cause and effect relationship. And a case of in Florida found that with virus particles in brain cells. And this might occur due to virus entering the bloodstream or nerve endings. The loss of smell that occurs in some patients with COVID-19 could indicate that virus entered through the olfactory bulb, which is located right above the nose, and that communicates information to the brain about smell. And I think this symptom probably wasn't recognized early on, but if you have gone to the hospital recently, they do ask people about this loss of smell and loss of taste. So olfactory bulb was thought to be the part through which it goes there. So the first thing they thought was just the severe infection. The second mechanism, what the researchers thought why COVID-19 affect brain is because of immune system is in overdrive. So what happens is it's a foreign body, it's a foreign particle. So immune system tries to fight COVID-19, but the inflammatory response that is produced by the body is different than what it does normally. So it's kind of a maladaptive response. And this may cause much of the tissue and organ damage that we see in this disease. And some people believe that more than the virus itself causing infection directly, it's more of the immune system in overdrive that is a cause why this virus affects brain. The third one is just the third theory, just the chaos in the body. It's because all of the physiological changes induced in body, COVID-19, ranging from high fevers to low oxygen levels to multiple organ failures, they contribute to and account for brain dysfunction. For example, the person may be in delirium and coma just because of having hypoxia, which is loss of uh, due to reduced oxygen, and may not be direct affection of brain cells. How do researchers think is affected, the brain is affected, is the fourth mechanism. And this has again become quite common, is the clotting abnormalities. The fourth way COVID-19 might affect the brain has to do with the tendency for these patients to suffer a stroke. So the blood clotting systems in patients with illness is highly abnormal. So the clots occur in patients with these patients more than others, and the clot can form in veins deep inside the body or in the lungs, where they can cut off the flow. Actually, we have, if at all, we did see strokes in patients with COVID. The cause was thought to be blood clots, and these blood clots were able to, they kind of block the blood vessels and especially the arteries that were leading to brain. And because of that block, patients had strokes. So I think for when COVID-19 caused stroke, the mechanism was a little more clear than rest of the symptoms. But the bottom line is, yes, strokes have happened in patients with COVID-19. So let's move on to seizures now. So studies with COVID-19 and seizures, there are multiple reports on COVID-19 that show that neurological complications are seen, especially seizures, when COVID-19 has affected the patient in a very severe way. So only in severe cases of COVID-19. Individual case reports provide some details of acute symptomatic seizures, but the question where the systemic complications or whether it's direct affection, so whether it's, you get any infection, even things like urinary tract infection or with any viral infection, patients with seizures are more prone to seizures during their time of infection. We call it provoked seizures. And the difference is during that time, if I see a patient in an emergency room who's come with increased seizures, but they are also febrile, they have some infection going on, and that is a cause of seizures, we don't necessarily increase their seizure medications. We say this is a provoked seizure, so it's kind of temporary effect of that infection, and we don't. Whereas here, we don't know whether when patients with COVID-19 get seizures, is it the effect of COVID-19 or is it just like any other infection? And there is no evidence from cohort studies that in general population that seizures were worsened due to COVID-19 or seizures were caused. No definite statistics on that. And that is partly also because there is lack of cohort studies in patients with history of epileptic seizures, and we can't really draw a definite conclusion. Overall findings indicate that seizures and epilepsy are rare just as a cause of COVID. Now, American Epilepsy Society did a very nice study. They did survey of AES, all those professionals who were members of American Epilepsy Society were contacted in May and June 2020, and almost all respondents, which were not necessarily physicians, any advanced practitioners like nurse practitioners, nurses, so they were contacted, and most of them were affected in some way or the other. Most healthcare providers did not perceive that people with epilepsy have experienced an increase in seizure frequency during the pandemic or as a result of COVID-19 infection. There are barriers to care. However, pandemic forced some innovation. Interestingly, I saw a patient today in my outpatient clinic. There was they're 70-year-old couple, and they have had their first grandchild, and they wanted to go to California. So they came like, would it be okay to go? And if we do, what should we do? And so on and so forth. And they are like, I told them I'm talking about this, and so they said, you know what? We are tired of hearing everything negative. In your talk, please mention something positive that came out of COVID. And I do think this is not my statement. This is something that came out of the study, but they did feel that there's some innovation like telehealth did take place. And this article is published just this month. Actually, I do have, this is, I don't know if you can see, Epilepsy Currents. Is basically what Epilepsy Currents does is they kind of put all the articles in the field of epilepsy that are high impact and useful for patients to get in that journal. And you may recognize one of the authors there is my better half, Dr. Acharya. But it's basic, every institute had one participant, and mainly all major institutes in America participated. I'll show you some parts of that. The key takeaways of that study. About the third, that is 30% of the respondents had encountered patients with COVID-19 who had new onset seizure, which they attributed to more like lower seizure threshold because of pre-existing risk factors and less due to perceived viral infection. So really most of us, this is all like basically our epilepsy group, and we did not feel that they were directly because of COVID. 1/3 of respondents had people with epilepsy in their practice who developed COVID-19, and in most of them, seizure frequency remained unchanged or showed a variable response. Increase was noted by approximately 16% of respondents. People with epilepsy without the COVID infection generally showed no change in seizure frequency, but a small number had worsening or improvement. Worsening was rarely thought to be, was mainly thought to be due to emotional stress. COVID-19 pandemic has not resulted in significant change in phone calls from patients to the clinics, although both increase and decrease calls were noticed, but people didn't feel that, patients got so scared that the providers started getting calls because of COVID-19. And 1/3 of the survey's respondents, COVID-19, they felt it may have resulted in less than the expected delivery of standard care. So people had problems with lack of access, etc. EEG volumes, this is one one field that was affected. EEG volumes had substantially decreased during the pandemic, largely because people did not want to go and get a test done unless it was absolutely necessary. And there were no significant shortages in medications, maybe some possible shortages of Keppra, the levetiracetam, and IV benzodiazepine, and especially midazolam. So this is a nice diagram which shows what were the barriers to care that patient with epilepsy experienced as a result of COVID-19 pandemic. And they had categories like, I'm not aware of any barriers. And if you can see that little green bar, very few people said, I have no barriers. And loss of employment, lack of access to healthcare services, lack of transportation, inability to travel, lack of access to technology, lack of access to anti-seizure medications, fear related to viral outbreak, not sure, don't know, and other. So surprisingly, lack of access to anti-seizure medication wasn't a high bar. I think most affected factors were loss of employment, financial stressors, lack of access to healthcare services, and I think it was just the fear related to pandemic. Again, most responders experienced some form of barriers to providing care, mostly related to access to in-person visits and testing. Most respondents seem to have an idea when their practices were going to return to pre-COVID levels, but there was a little agreement on what exactly it would be. Most of us have successfully adopted to telehealth, and that is something positive. Although I was quite surprised oftentimes that people did not have access to email or internet, and telehealth was not always a possibility, not in everyone. And COVID, it has affected the education of our medical students. And what we are worried about is the future generation. While they are in medical school, they learn about epilepsy and seizures. To a certain extent, that education was affected. Uh, Another thing that we commonly and most of you would come across is EEG screening and triage in EMU. So if a patient is having increased seizure or there is a change in your type of seizures, typically we say in a clinic visit that let's admit you to the epilepsy monitoring unit and have the video EEG testing done, where we'll have you on video and see the seizures as well as see where the seizures are coming from. In the COVID pandemic, what we have been doing is consider home monitoring and then have the leads attached like extended EEG and obtain video at home. And if the patient had those who have failed empiric treatment with medications, the next option is surgery or neurostimulation, either VNS or RNS. I think even in those cases, what we are trying to do is we assess the urgency and the disease burden. If we do it now or we do it when the pandemic ends, and again, we don't have an answer for that, but is it going to be a big difference? Is it absolutely necessary to do the surgery now and then go ahead with those decisions? If we have to admit the patient to epilepsy monitoring unit, I think the protocol that is nationally followed is there is a COVID testing required pre-admission. And if testing is not available, at least do the enhanced screening of the questions. I don't think that is really recommended. At our center, we do the COVID testing, then we call the patients 2-3 days prior to admission, make sure they don't have new symptoms. And again, on admission, we make sure that they are symptom-free and COVID-free. And again, the visitation, typically we used to allow more people in the EMU to stay with the patient. Now the visitation is limited to just one person. And we also ask our patients to self-quarantine before the admission. If we have to do the EEG on a patient, and most of you are familiar with the EEGs, typically we want to make sure if the patient, and we have had these situations. In fact, currently there is somebody, a COVID positive patient comes with something, a suspected seizure. We don't deny EEG testing to them, but what we make sure is the appropriate protective equipment is there for the technologist, and we also mask the patient. The main thing here is we do EEGs on multiple patients, and typically, so in this case, if the electrodes are used on a COVID positive patient, they cannot be used again on any other patient. So the first and foremost thing is disposable electrodes. And as you know, during the EEG testing, we do hyperventilation. We avoid hyperventilation unless the patient has epilepsy, like childhood absence epilepsy. In this type of epilepsy, hyperventilation is really useful in making a diagnosis. So we may consider. And when we use collodion for the leads, instead we try to use something else to avoid use of air hose. Treatment and vaccine, there is no specific treatment currently available. The antiviral medications are under investigations and vaccines are under development. And that is pretty, and how does the virus survive? Somebody asked, how does it survive outside the body? It's not clear how long it stays on surfaces. And I'm sure most of you have been reading about it. And, you know, any store you go or any hospital has this data available. But I just looked at the EPA guidelines, and EPA says the virus may persist on surfaces for a few hours or up to several days, depending on conditions and the type of surface. So again, it's not very clear. But the good news was that a simple disinfectant may, just get rid of the viruses. So if you have watched the news with our governor and Dr. Rachel Levin, I think I like that, the happy birthday and washing your hands. And, it is so, I don't know how long we have been doing that, probably the instruction 6 months, and I don't know how many more months or entire year will do that, but those simple precautions do help. Now, this is all about the medical part of neurological complications. See, I just kind of was trying to think when I got into this, just, how much our life has changed since December 19. I don't think we were aware of this in December 19 so much. And I just put in together, I may not go through all of this, but in January, it's the first, WHO announced the first case. And then on January 20, CDC said 3 US airports, they started screening. On January 21st, we had first case detected. And on January of 21st, the Chinese scientists confirmed COVID-19 human transmission. And on January 23, Wuhan was under quarantine. Then January 31st, WHO declared this as a global health emergency. The travel was restricted on February 2. US declared a public health emergency on February 3. And the pandemic was declared on March 11th. And March 13th, we declared a national emergency. The travel ban for non-US citizens traveling from Europe went into effect on March 13. Around this time, actually, I wanted to visit my mother and was planning to travel, and I'm sure many people who wanted to travel could not do that. And then around March 17, the testing of hydroxychloroquine started. Telehealth came into effect more in March 17. First state to issue stay-home order was March 19 in California. Actually, I don't remember when it happened in Pennsylvania, but I think it was soon after that we had that order too. And then the shutdowns happened, CARES Act came, and the FDA initially authorized the hydroxychloroquine, and then the cocktail came into the picture, NIH trial finally showed the early promise of remdesivir. Another new testing came for in-home use. In March 12, it was announced that the death toll was likely underestimated. United States and AstraZeneca, they formed a vaccine deal. The cases exceeded 100,000 mark. And this article, actually, I did review in detail the Lancet article. There were a lot of these studies on hydroxychloroquine, and they went back and forth. Initially, it was thought to be effective, then not thought to be effective, and then it was used. Then the cases reached 2 million. And finally, the hydroxychloroquine ended. And I think the remdesivir kind of is still there. This is just for, food for thought. I'm putting all these slides. The cost of these medications, if somebody really gets it. So that's a company that makes the medicine. It was said to be $3,120. And finally, in June, they announced that the cases would hit 100,000 a day. And the cases, now they're saying that there are more and more cases. The bottom line is it has affected the medical world. It has affected the world of neurology to some extent. World of epilepsy, as we saw from those graphs, I think the main points were just the financial loss and fear, like anything else. By itself, the virus has not increased seizures. So that's all I have to say. And I know that was too much to take, but again, I think this is a topic where we are all learning. So if I missed anything, and if anybody has anything to add specifically for epilepsy patients from your experience, please feel free to do so. Thank you.